So presenting for us, we have Dr. Melanie Hoppers. She is board certified in internal medicine and pediatrics, working with the Bateman Horne Center of Excellence. She provides clinical, oh, I'm sorry, I'm flipping up today. She provides clinical care education and research on MECFS and long COVID and has spoken widely on pediatric post-viral syndromes and complex chronic illnesses. So I will go ahead and pass it over to you, Dr. Hoppers. Thank you for joining
Okay,
us today.
thank you so much. Let's see if I can manage to do this seamlessly, which rarely happens. Okay, let's see. Do you see my slides okay? Okay, wonderful. So thank you again for allowing me to speak today. I really do appreciate the opportunity. Um, let's see. I don't have any disclosures to discuss, and consent and assent has been obtained for any patient cases that are shared. Some details have been altered, and cases combined to protect confidentiality. So I do come from the Bateman Horne Center. We are a 501c3 nonprofit organization. We focus upon clinical care, research, and education regarding infection-associated chronic conditions and their comorbidities. My objectives today is for you to feel confident recognizing pediatric long COVID, also MECFS, and to have some practical tools for assessment and management. So current estimates suggest that nearly 6 million children in the United States may be living with long COVID. To put that number in context, this exceeds the number of children living with asthma in the US. This has historically been considered the most common chronic illness in pediatrics. Additionally, many, if not most, of these children living with long COVID are not actually diagnosed. And even those who are, there are no FDA-approved therapies currently available, no clinical guidelines. This leaves millions of children with few treatment options during the most critical years of their development. So the National Academies of Sciences, Engineering, and Medicine defines long COVID as an infection-associated chronic condition. There is no biomarker for diagnosis, and so it must be diagnosed clinically. Symptoms must be present at least 3 months. The clinical course can be continuous, relapsing and remitting, or a progressive disease state. Long COVID can affect one or more organ systems and can cause one or more symptoms. It can follow an asymptomatic, mild, or severe SARS-CoV-2 infection, and importantly, does not require a positive COVID test. It can exacerbate pre-existing health conditions or present as new ones. And it's defined this way. It's a very heterogeneous condition, ranging from a single lingering symptom to debilitating multi-system illness. So in pediatrics, there are certain risk factors that are present. One is economic instability. If it includes food insecurity, this is associated with a increased risk of long COVID. As their age increases, so at adolescence, we'll see a sharp rise in cases. Additionally, the higher severity of acute COVID illness, just like with adults, is a risk factor for pediatric long COVID, also pre-existing conditions and increased weight status. There was a recent study that showed a 50% increase in long COVID with a second infection. Unfortunately, this was not mitigated by vaccination. However, vaccination reduces the number of acute COVID-19 infections, so it does ultimately reduce your risk. So long COVID in children can be persistent. Some early in the pandemic, early in understanding about long COVID, it was thought, well, kids aren't really that affected. They don't get long COVID. Oh, but wait, they do. Maybe it doesn't last very long, but actually it seems to be somewhat persistent. This was a study done in Rome, Italy, at a post-COVID clinic, and they looked at symptom prevalence of long COVID up to 24 months. And what they found is at 3 months, 23% had symptoms of long COVID. At 6 months, 13% were still affected. At 12 months, almost 8%. And at 24 months, still 7% were affected. I can tell you this, I have patients with long COVID who were affected early in the pandemic around 2020 and are still sick with the illness. So certainly that's not a study, but I can tell you that there are patients that are still sick. So, this information about quality of life comes from a retrospective study that was conducted at Johns Hopkins. And in this study, quality of life scores were evaluated for children living with long COVID. Scores of 70 and below are seen in major chronic illnesses such as cystic fibrosis and cancer. The mean overall score for patients with long COVID was 55. School functioning was severely impacted at 44. Physical function is also significantly limited at 49. What this data tells us is that pediatric long COVID is a serious chronic condition. It requires the same comprehensive medical care, educational, and social support we provide for other major childhood illnesses. Now, this next slide is a patient, and there. This is actually my daughter. She didn't have long COVID. She doesn't have long COVID, but she was infected with Epstein-Barr at the age of 10. And she never recovered. She has a diagnosis of ME/CFS, and we'll discuss that as we go along. But she's never recovered. She's now 21. But I want her to tell you a little bit about her life as was impacted with this illness.
Hello, I am Sarah. I'm 21 and I live in West Tennessee. I became sick at 10 years old and it immediately affected nearly every aspect of my life. But most severely, it affected me the most socially and academically, which I feel like go hand in hand. At that age, I was a normal, happy, active, good student. I always had great grades. I had a wonderful group of friends. And that all changed the moment I became sick. I was very isolated from my friends at the beginning of my illness when I was bedbound. And my grades started to plummet in my classes. And me, being the perfectionist I was at that age, that took a toll on my self-esteem. The sudden change in my health, combined with being labeled a bad student, the cherry on top being that I rarely ever saw my friends, it's not hard to guess that I soon became a very unhappy child. Something was obviously wrong with my health when years went by and I wasn't improving and getting worse in some aspects. Something was obviously wrong, but nobody really knew what it was. And so that's when the parade of doctors entered my life. And each one misdiagnosing me with depression and anxiety, or telling me that I was out of shape and needed to exercise. That was a common one, which, let me tell you, as a teenage girl, you hear that enough times. It's not good for your self-esteem. One putting me on a stimulant, another telling me to get off of it and don't even drink caffeine. Every doctor's appointment felt confusing and conflicting to the last. It made me feel hopeless. I felt criticized. It was very frequent that it felt like it was implied that I was straight up lying or maybe exaggerating my symptoms. And that is quite a lot to deal with as a young kid, as a teenage girl. And it was especially difficult seeing how normal my friends were in comparison. I could not wrap my head around how they could go to school for 7 hours a day, keep their grades up, do sports, join clubs, and still have time to, or still have the energy to hang out with their friends after the day was done. So that made me have many moments where I thought, well, maybe those judgmental doctors were right. Maybe it is depression. Maybe it is all in my head. Maybe I am just lazy. Maybe I do need to go exercise. and I began to think of my illness as more of a character defect rather than a disease that I could not control.
Okay. So going back again with her, she had mono at the age of 10, and she's still ill at 21 with something called myalgic encephalomyelitis chronic fatigue syndrome. So I want to let you know how that interacts with long COVID. So infection-associated chronic conditions such as long COVID have been described as early as 200 years ago. Many different infectious agents have been implicated, including but not limited to Epstein-Barr virus, West Nile virus, enteroviruses, HIV, Giardia, also bacteria like Borrelia burgdorferi. So there's a subset of people with infection-associated chronic conditions with more severe and persistent symptoms, and these can be further categorized as having myalgic encephalomyelitis chronic fatigue syndrome. This is also known as ME/CFS. And in 2015, the International Association of Medicine developed criteria for the diagnosis, and there are three major criteria. One is substantial impairment and the ability to engage in pre-illness capacity that lasts 6 months or longer and is accompanied by fatigue. So how does this look in kids? It's a little bit different, right? In adults, people can't go to work or they can't work and do other things. In children, it may be an inability to attend school full time. It may be the inability to attend school and do anything else. They may come home and sleep 3 hours. It may be in younger children, it may be failure to thrive or failure to advance in their milestones. Additionally, they must have post-exertional malaise, and we'll talk more about that in a little bit, and unrefreshing sleep. And in children, again, as in adults, it manifests essentially what we're saying is when they sleep, it's non-restorative. They may have hypersomnia. They also may have insomnia. They may have disrupted sleep. Then additionally, they must either have cognitive impairment or orthostatic intolerance. In my pediatric population, I really see both a lot of the time. So here's sort of a summary of what can happen with an infection. You can substitute SARS-CoV-2 with mono and other infectious etiology. So you get an infection, and in kids, 80 to 90% of the time, symptoms resolve and everything goes on. Fortunately, it's rare, but there are more, serious complications such as end organ damage with severe infection and even death, unfortunately. About 10 to 20% of the time, patients will develop long COVID. Of those, many will have symptom resolution. Others will have continued symptoms, but don't quite meet that criteria for ME/CFS. Remember, the definition by NAM is that it can even be a single symptom. So you can have a patient with, lack of the sense of smell, but then you may have a patient who meets that criteria for ME/CFS who is bedbound or homebound or can't attend school. So in children, as in adults, any organ system can be affected. Frequently, I see fatigue. Fatigue, and more fatigue. A lot of sleep issues. I see a lot of kids with hypersomnia. Then I also see kids with insomnia or, feeling wired but tired, so they're exhausted but they can't sleep. Oftentimes there are GI symptoms with nausea, diarrhea, constipation, bloating, food intolerances, headaches. I see a lot of behavioral changes. I see attention deficit disorder, cognitive problems, and kids don't often recognize that they have cognitive issues. They just think they think they're not learning well. They don't understand that there is a problem. So oftentimes with kids, they don't recognize these symptoms, but parents will come in and mention them. So this was a study done by the NIH Recover group, and they looked at about 5,000 children. They looked at school-aged children and adolescents, and they wanted to characterize what type of symptoms were being seen. And so what they found is after a COVID infection, that about 20% of school-aged children and 14% of infected adolescents met criteria for probable long COVID. So in adolescents, they more commonly had change or loss in smell or taste. They had a lot of muscle and joint pains, daytime tiredness, low energy, trouble with focusing, lightheadedness. That's probably orthostatic intolerance. In school-aged children, there was more trouble with memory. Again, back or neck pain, stomach pain, headache, phobias. itching, rashes, trouble sleeping, nausea or vomiting, feeling lightheaded or dizzy. I mean, all of these symptoms just kind of go across the board, right? Now, these are not essential for diagnosis. But they also don't necessarily implicate long COVID. But these are symptoms just to kind of give you an idea of what we see in the different age groups. Sadly, the next slide actually is even more dire, in my opinion. So then they came with this study in December 2025, and they had extended their work to even younger children. And they found that about 14 to 15% of younger children were identified as having probable long COVID. Similar rates to the older children, but again, distinctive patterns. The preschool age children, 3 to 5, had daytime tiredness, sleepiness, low energy, and cough. Infants and toddlers had poor appetite, trouble sleeping, fussiness, wet cough, dry cough, and stuffy nose. So essentially, everyone is open season for this illness. So when do I consider long COVID in children? So this can be really, really tricky. So in kids, if you have a child who comes in, they have a COVID infection, and then a month later they come back, never really recovered, still having symptoms, now developing new things. 2 months later, new symptoms are developing, they're still not well. It's, you've got the timeline. It's fairly easy to connect the dots. However, oftentimes in children, they have these subclinical infections. They have just a runny nose, a cold symptom, and in a busy family, you don't necessarily need to go to the clinic and have someone see them for this. Or if they do go to the clinic, they may not be tested. So there's no clear diagnosis of an infection. And so I remember when I was a young mom with several kids in tow, a runny nose didn't necessarily hit my radar. A month later, I'd forgotten about that. So as a provider, you really have to think back. You have to help them, try to go back and think about these things. Or did someone else in the family have COVID? Sometimes that's been a helpful indicator for me. But what you'll see are these kids who were healthy before, didn't frequent the clinic very often, but now all of a sudden they're coming in. They're coming in, every month, every few weeks. They may have, this time they may have what looks like the flu. Then they come back and now they have headaches. Then they come back and now they have GI issues. Now mom brings them back because they can't get them to school every day. So in younger kids, it may be failure to thrive, failure to progress with their milestones. They may have regression of their milestones. So just things aren't the same. I hear a lot of they used to do X, Y, or Z, and now they can't. So that's something, if that pops up, have that on your radar to start digging for COVID. Symptoms worsen after exertion. This represents post-exertional malaise. Again, something we'll talk about. Kids who come in with POTS or with orthostatic intolerance, orthostatic hypotension. If you start considering this diagnosis, start thinking about long COVID. If they have unpredictability to their health, one day they're good, the next day they're bad. That's another indicator for me. So what do we do? Just what we do in every other illness with kids. Do a good history and physical. Ask the questions, spend the time with them. Remember, these are a little harder to describe for kids. Cognitive dysfunction is not as easy to describe as maybe a sore throat. How do they describe cardiac symptoms? If they have orthostatic intolerance, they may say they have chest pain or trouble breathing instead of palpitations or tachycardia. With cognitive dysfunction, they may say they have a headache when it comes time to do homework. They may say they just don't feel well. We want to screen for, we want to do a good physical screening for neurological issues, do a Beighton score. This is checking for hypermobility. At the end of the talk, I have a QR code and it'll have things like how to do a Beighton score for you, some just nice tools. It's really easy to do. I learned it by reading about it. It's not, not some difficult thing to do. I look at pupillary size. Oftentimes kids will have huge pupils because they have dysautonomia. Look at their capillary refill. I do a passive stand test on every child who's old enough. If they're 6, I don't, but if they're 12 older, I'll do a passive lean test because I almost always have some findings on that with long COVID. Diagnostics, a symptom-focused diagnostic workup. I do a lot of sleep studies, have found a lot of sleep apnea as well. It seems it's doesn't rule out long COVID, but this may be going along with it. Various labs. Again, this is just kind of a reference slide for you. Some labs that we get, again, depending if they don't have GI dysfunction, I'm probably not going to do look for celiac, but do a symptom-focused lab review as well. This is a really great tool. I believe Cindy Bateman, Dr. Bateman at the Bateman Horn Center developed this. I say I believe because I'm not 100% sure and I don't want to credit the wrong person, but I think this is a brilliant tool. It's called a good day, bad day questionnaire. And it simply asks, how many bad days do you have a month and how many good days do you have a month? Sometimes I have to change it to how many bad days and how many better days, because some people say I have 0 good days. Then what I want to know is, what can you do on a good day and what can you not do on a good day? What can you do on a bad day and what can you not do? So if somebody says on a good day, I can go to school, but I can't do my extracurricular activities and I have to come home and take a nap. On a bad day, I can't go to school, but I can warm up food in the microwave. That tells you something, right? You also may have somebody say, on a good day, I can get up and go to the bathroom by myself. I have severe teenage patients. I have a severe patient who's 10, who cannot leave their bedroom, who cannot leave their bed without assistance. So this is how sick kids can get with this. But this gives you, in 30 seconds, I can look at this and know their functional, I get a good indicator of their functional capacity. It's really, really helpful. We also ask about hours of upright activity. And I have to define it, and sometimes I have to define it a few times because it doesn't quite, you have to really listen to what we're talking about. It's with feet on the floor in a 24-hour period. If you're standing, if you're sitting with your feet on the floor, or if you're walking, that's hours of upright activity. If you're sitting with your legs crossed, if you're sitting in a recliner with your feet up, that doesn't count. So you'll start to hear, in patients who are impaired, you'll start to hear 12 and less. You know, if they say 10 hours, 8 hours, and this is an average, right? So on a good day, they may be up 12, but on a bad day, it may be 4. So they, end up with an average of somewhere in the middle. So it can be a helpful indicator as well. I can quickly see kind of what shape the patient is in. So I love this tool. It's really, really great. So I want to switch gears a little bit and talk about post-exertional malaise. So what is post-exertional malaise? It's sometimes referred to as PEM. It is defined as the inability to recover normally following exertion. Exertion includes anything that consumes energy, not just physical activity, but also cognitive activity, emotional, social, environmental activity. Whenever I think about PEM, I picture kids going to school, and I think about it and I think, oh my goodness, this is such a setup for PEM, right? There's the cognitive, the social, the emotional activity. Think of our teens. I think of myself as a teen. I was just a bundle of emotions. And it just, all the things they go through just getting to school and going to school and doing their schoolwork is such a setup for PEM. PEM results in a worsening of their symptoms and functional ability and results in profound fatigue. It's not just fatigue, though. People often hear this and think, oh, they're very tired. Yes, they are very tired, but additionally, there's immune things going on. There's autonomic dysfunction. There's metabolic inefficiencies. It's more than just being tired, and we'll get more into the symptoms that they have. PEM can be immediate, but often it is delayed, occurring 12 to 72 hours after the exertional stressor. There's prolonged recovery. It's way out of proportion to what they previously could do. And recovery may be days, weeks, and even months to recover, depending on the severity of how severe they are at baseline. So I do a lecture on PEM and I go through all these studies and how, what's going on. And it's too much to get into in this talk, but this is my summary slide. So I'll just tell you a little bit about the pathophysiology. So there's a decrease in peak VO2 or their capacity to exercise. There is a lowered anaerobic threshold, so they more quickly convert from aerobic metabolism to the less efficient anaerobic metabolism. Some people, it may be walking a block. Some people, it may be getting up and doing their ADLs. There's also exercise-induced reduction in skeletal muscle mitochondrial enzyme activity. There's decreased oxygen utilization by peripheral tissues. Additionally, there's muscle tissue damage seen with exercise. There was a biopsy study that showed there was a higher proportion of highly fatigable glycolytic fibers compared with controls. And there was a recent plasma proteomics study that showed sustained immune dysregulation, upregulated glycolysis, indicating mitochondrial stress, and decreased muscle proteins. All of this is a lot of words, right? Just hearing this is a lot. And my point is that there is a physiological basis. PIM is such a foreign concept. Until I saw it in action, it was really hard to understand it, really hard to believe it, even. But I would see it in my child. I would see she would go to school, come home and sleep for 3 hours, then every weekend was spent on the couch, not playing with her friends, not doing the fun things. And she was trying to do the things she was obligated to do, but missing out on all the other things. When someone said push crash, when I read push crash cycle, I was like, that's it. That's exactly what she's doing. So this is what it's like for the patient. How do kids describe it? Right. I've heard one of my teen patients called it, he said it was like I'm on the Gravitron ride. I've never been on that. I'm sure that I would not do well on it, but his implication was that he felt pinned to the bed. I've heard it described as encased in concrete or walking through mud. I'm feeling like their limbs are heavy. My daughter called it, I'm sick. She just said, I'm sick. That's all she could think of. Many times kids will come in early in the illness, frequently to the clinic with symptoms of flu or strep. They'll have sore throat, swollen lymph nodes, maybe a temperature of 100, not quite, a high fever, but enough to make you start swabbing them. You do all the swabs. You do it 6 times in a year and you go, gosh, this kid has been in a lot, but nothing. Maybe there's a strep here and there, but for the most part, nothing really shows up. Eventually they quit coming because mom realizes, or dad or caregiver says, we do this frequently and nothing ever shows up. Nothing, there's appropriately no antibiotics given or what have you, so we don't come in anymore. And it kind of burns itself out a little bit. Also, everything is worse. I want a banner. I want to just be able to click something on my chart when someone comes in with PIM. Patient is in PIM, everything is worse. And then here's what else has happened. They'll oftentimes develop new symptoms. If they have headaches, they may develop a new character to the headache. A lot of sensitivities to light, sound, smell. I find a lot of behavioral changes. Kids may get very quiet. They may be distant. They may be irritable. A lot of sleep issues. And all of this is the same as with adults, right? But sometimes can look a little bit different with kids. But they'll have the sleep issues. But the thing about kids is they don't know what's going on. They don't understand. They may not be able to verbalize it. Think about the little children that age group I was talking about earlier. It may just manifest as a crying infant. Again, not being able to play, not being able to do, not being able to feed, they may be failure to thrive. So it's going to look a little bit differently in those children. So why is it important besides the utter misery of it? Repeated episodes or a particularly severe episode can sometimes result in a worsening baseline. It's been postulated that these neurophysiological responses may accrue over time and leave permanent injury to neuronal networks. This is particularly worrisome to me with kids. You start at 10, you start at 6 with this illness, you have a lifetime to live. And repeated episodes of PIM can worsen your baseline. So that's very scary to me. So again, something we really want to talk about with our patients. There was a study conducted by Dr. Leonard Jason in 2009. And this was with adults, but they looked at a group of patients with ME/CFS and who had PIM, and they divided them into groups. They counseled them all about PIM and how to try to stay in their energy envelope. At the end, they separated into groups who could and who could not manage to pace effectively. Those who did pace effectively had improvements in their physical functioning and fatigue severity. So this gives us evidence that this can be an effective tool for PIM treatment. So how do we determine if a patient is in PIM? Does it take you longer than 24 hours to recover from exertion? This is really key. A lot of illnesses can sound very similar, but if it takes longer than 24 hours, that's really a key finding. In addition to fatigue, do you have physical symptoms? Do you have more pain? Do you feel bad? Do you have body aches? Do you have sore throat, swollen lymph glands? Do you have cognitive symptoms? If you go and, if you have extracurricular activity, you go on a school field trip, and then the next day you can't think clearly, or at the end of the field trip you're kind of fuzzy headed. That's something to take note of. Do you have push crash cycles? Do you pay after exerting yourselves? I ask teens a lot of times. So when you have the end of semester and you have all those exams at the end of the school year, how do you feel at the end of that? And they'll usually look at me, and go, "Oh, I'm terrible. I go home and sleep for 3 days." Are the symptoms sometimes delayed after the activity, or do they worsen before they get better? And ask about sleep. Sleep disturbances are so common during PIM. That can be a really helpful indicator as well. So, what can we do? Again, we want to pace. So, the first thing I do is I want to pace their visit. So, if I believe that pacing is important and I believe that exertion can make you worse, and you come to my office and I make you worse because I spend time and I don't accommodate for you, then I'm not setting a very good example. So, okay. So Dr. Bateman used an analogy the other day, and I thought it was so good. She was talking about what can you do about PIM, and she compared it to a sunburn and said, it's like a sunburn. When you're out in the sun, you don't always know when you've overdone it. I know I've done that. I've been out there thinking I am sunscreened up, everything is good. Everything is great. I've done all the precautions, and then I get home, and that evening I start to go, oh, uh-oh. And then the next day, and maybe the next day it gets worse. And you really can't do anything. You can put creams and such on it, take some NSAIDs, but you're just going to have to, give it some time until it gets better. And that's the way it is with PIM. So really, we want to prevent PIM with pacing, but there's what can you do during PIM? There's not a lot. We want to, provide reduction of sensory input, eye mask, a cool dark room, earphones can be helpful. The biggest thing a parent can do is to just stop all the activity. I used to have this bad habit of going in and checking every 5 minutes. Are you okay? What can I do? What can I get you? I was making it worse. Just learn to hands off. Leave your child alone. You can comfort them, but try to be, quiet, low impact. Keep a small footprint when you're around them. Help with relaxation techniques. As a provider, you can help with sleep management. Do the things that you normally do for that. I have them consume a easily digestible, bland diet. Again, it's sensory input. It consumes energy. If you have a more robust, spicy foods at that time, it's not the right time. And mast cells really don't like it if you're doing that. And I think I must have missed a slide, but pacing, accommodations, modifications, be sure and add those. Don't just say, give them more time for a test, have less test questions, because the child just gets further and further behind. And now they're trying to homeschool on their own, with homework that they take home. And if it's the same amount of work, they can't do it. So also prioritize, school is great. We want them to learn, but they also need that social interaction. So it may be best to let them have some time for extracurricular activities and they have less school time. Whatever you can do to help them keep that social contact is really, really important. I've heard adults say, I'm grown up now, but they just didn't have that social interaction, and now they're behind with that. So you want to continue that as well. And that's about all I had. I was going to do a patient case, but I think I'll leave that off since I've gone over. So, are there any other questions?
I did put in my question is like, to our understanding from what other groups have mentioned about long COVID, that pediatric long COVID is a multi-system inflammatory syndrome. Do you think that using anti-inflammatory agents would be of any benefit? And then are there biomarkers? I saw your list of biomarkers that or blood work you do. It didn't contain that many inflammatory markers or do you think that it's of importance or?
Well, I was reading an article this weekend and it talked about there's no biomarker to tell us you have long COVID. What I'm doing with my labs is making sure you don't have something else. I had a patient that came in, they had a COVID-19 infection, or illness, they were fatigued, their lean test was positive. I was certain this kid had long COVID, but I checked and he had adrenal insufficiency. Now he probably technically did have long COVID because he had multiple endocrine issues and autoimmune issues. And I believe that maybe COVID had triggered it, right? Just like we know there's an increased incidence of type 1 diabetes after a COVID-19 illness in kids. So you want to be on the lookout for that. But, had I not done my due diligence and looked for other things, when I was so certain, this was early and I was all excited, not excited that he had long COVID, but I can help you, I can do something. And, ooh, it's a good thing I checked because there might have been some serious this kid his numbers were really, really bad. But so those are the things I'm really looking for to make sure they don't have something else. And especially with kids, they're young. They haven't had time necessarily to have these other things manifest. So you want to make sure you're not missing something. Again, I had a kid recently. She has long COVID. She was having hallucinations. And I can't remember why, but I checked. We did a sleep study. And she did have sleep apnea. She's on CPAP now. Her hallucinations are better. Now, she still has long COVID. But you want to do all those things, look for the other things that could be causing issues. There's not the most normal labs I get are in kids with long COVID. You always have that little something that's off, the little number that's off here, the number that's off there that's not really even clinically significant. But in kids with long COVID, they're the ones that will have the most perfect labs. There's been some studies that have shown increase in IL-1, IL-6, interleukin alpha, beta, tumor necrosis factor alpha. I don't do those routinely because they don't add anything. If they are abnormal, it doesn't change what I do. It's nice and it's interesting, and there need to be studies with that, but they aren't particularly helpful for what I do. In our treatment, there are some anti-inflammatories that I use. Again, in kids, I have to be really careful. I don't do a lot of off-label prescribing. In the more severe kids, I do, because when you're home and you're bedbound, we're going to try something. I'm going to try something with those kids. I've been that desperate person, that desperate parent who do something for us. In the more mildly affected, I don't, and we'll talk more about that in the next talk with the mast cell and orthostatic intolerance. We'll talk more about some other options for treatment. But trying to think if there's anything else that I do along those lines. That's pretty much it.
And then I don't know if you noticed, we do have another question in the chat. How do you tease out the pubertal, I knew I was going to say that wrong, changes that occur in pre-adolescent stage or other stage related causes of fatigue versus PEM?
Again, it's different. Fatigue is different from post-exertional malaise in that it's not just fatigue. If you kids who are tired, say, kids are tired, right? Like you said, healthy kids oftentimes sleep a lot through the weekend, but these are kids who additionally will have aches and pains. They'll look flu-like. They may have a low-grade fever, sore throat. They'll have swollen glands oftentimes. It'll last more than 24 hours. They may have cognitive deficits. They may have behavioral changes. Oftentimes, the kids will get more quiet or get a little bit more irritable. It may get worse before it gets better, and it's related to exertion. It's related to multiple exertions. Again, a kid maybe has a busy week at school. I think of the kids who are in theater. At the end of the production, then they crash I had kids in theater and they would crash for a day or two, but this may be a crash for a week in addition to those physical sick symptoms. So that to me is how it's different.
Okay,
And
well,
I will
go ahead.
say real quick, I'm sorry. One of the factors that is makes it even more confusing with kids is I'm convinced that when kids go through growth phases, that they may have post-exertional malaise. So it seemingly is out of nowhere, and you can't prove that that's what's going on at the time. But I think kids can be a little bit more unpredictable because of that.
Okay, wonderful. All right. So one of our participants just has to go because she has a patient waiting, but she wanted to thank you
Thank you.
very much for the
Thank you.
presentation. It was very
Thank you.
helpful. Let's see. Okay. All right. So if we don't have any further questions, I don't see anything coming up. So first of all, thank you, Dr. Hoppers, for
You're so
presenting for us
welcome.
today. For everybody that attended, make sure to complete your evaluation. And then our next session is on May 24th when Dr. Hoppers will be joining us again for part two. And the focus on that session will be recognizing and treating orthostatic intolerance and mast cell activation syndrome. So we hope to see everybody there. Have a great rest of your day.